Right. So this is Dr. Mariam Al-Abdallah. I'm a professor in orthodontics, and I'm a senior consultant at the University Hospital. This is the first lecture in your orthodontic theory course, and this course is an extended course that uh, starts and continue first and second semester. Along with it, you will have a practical course, lab, and it is also an extended course. Our basic and main reference is a book by Laura Mitchell, Simon Littlewood, um, An Introduction to Orthodontics, 5th edition. Sometimes we will use few chapters or parts of another book, that's Handbook of Orthodontics by DeBies Coburn. And, sometimes we use articles or chapters of other books. It depends. It depends on the topic, and the lecturer will provide you with the references at the beginning of each lecture. The first semester we're expected to cover 14 lectures, and second semester another 14 lectures. And we try to make the topics parallel with those that you will be covering in your lab, the practical part. So, for example, we're going to start with the introduction to orthodontics, terminologies, and a classification of malocclusion today. And the first session in your lab is going to be the same, terminologies and classification of malocclusion. This will be followed by removable appliances in theory as well as in the lab. So make sure to attend or listen to your lecture and study it so that you will be prepared for your practical session. So this is second semester lectures, and this is the lab schedule. As we said, each student will have one lab session of 2 hours every other week. So it's not going to be every week. So in total, you will have 7 sessions in the first semester and another 7 sessions in the second semester. The first one is going to be Introduction to Orthodontics, Terminologies, and Classification. So you have to listen to this lecture before you attend your lab. There will be a group discussion and clinical cases to apply the knowledge that you got from your lecture to get a better understanding of these terminologies, and so on and so forth. We will provide you with all the online materials, lab manual, and other stuff. These will be loaded on your e-portal, so make sure to open it every now and then to check any updates. Today's lecture is going to be mainly an introduction, and although we have different headings, but most probably the topics will overlap. So, for example, in the indices in orthodontics, we will have some terminologies introduced to you, classification, other terminologies, and so forth and so on. So, to start off with, this is the first time you take a course called orthodontics as a fourth-year student. So basically, it's that branch of dentistry that is concerned with facial growth, development of the dentition and occlusion, and it is responsible for the diagnosis, interception, and treatment of occlusal anomalies, malocclusion. And some references, you will find that they really focus on defining orthodontics as straightening of teeth, that branch that straightens teeth, but this is not really what it is. It's mainly, according to the American Association of Orthodontics, it is concerned with the supervision, guidance, and correction of growing and mature dentofacial structures. When we say growing, we mean children. Mature dentofacial structures, we mean adults, including those conditions that require movement of teeth, but not only. Also, correction of malrelationships of related structures by the application of forces and or the stimulation and redirection of the functional forces. The difference between forces here, the first one here is the forces that is produced by the appliance directly to the tooth. Functional forces are forces produced by modifying the structures and tissues surrounding teeth like, for example, muscles, functions of tissues, and they will produce forces that are necessary to modify the position of teeth. Right. Since we're talking about occlusion, it's important to understand what that is. I know that you took a whole course about it, but here we're concerned with the relationship between the maxillary and mandibular teeth in the maximum intercuspation, but you also need to know that occlusion is the relationship between teeth, muscles, skeletal structures, temporomandibular joint, nerves, functional jaw movements, relationship of teeth in the centric occlusion, centric relation, and during function. So it's really the relationship between teeth during function and as well as maximum intercuspation. Occlusion could be classified into ideal occlusion, which is a little bit of a rare finding, normal occlusion or malocclusion. Now, both ideal occlusion and normal occlusion can account for about 35% of the population, where the rest, 65%, will have a certain type of malocclusion. When we say normal occlusion, it means that the patient does not have the ideal occlusion, the perfect occlusion, no. He or she will have a little bit of deviations from the ideal that should not affect aesthetic or function. If these deviations should affect aesthetic or function, then we're talking about malocclusion. So the majority of the population will have malocclusion and the rest will have the normal occlusion, and a little bit of the population, maybe less than 2%, will have ideal occlusion. To describe normal occlusion, Lawrence Andrew took 120 study models for patients with beautiful occlusion, males and females, and he studied those study models thoroughly, made lots of measurements, and he came out in the 1970s with what we call the 6 keys to normal occlusion. As we're talking about these keys, we're going to be introducing you to some terminologies. Okay, so for example, the first key is talking about the molar relationship. When we say molar relationship, it means the anterior-posterior relationship between the upper first permanent molar's mesobuccal cusp in relation to the mesobuccal groove of the lower permanent first molar. Okay, the mesobuccal cusp of the upper should occlude in the mesobuccal groove of the lower to call this a normal molar relationship, or a class 1 molar relationship. Okay, so this is the proper definition of the molar relationship. But Andrew did not rely only on the mesobuccal cusp according to the traditional definition of the molar relationship, but he also added that to have the perfect molar relationship, we need to have the distal slope of the distal buccal cusp of the upper 6 in contact with the mesial slope of the mesiobuccal cusp of the lower 7. Okay, so this is the ideal molar relationship according to Andrews. So mesobuccal cusp of the upper 6 fitting in the mesobuccal groove of the lower, this is what we call class 1 molar relationship, and the distal slope of the distal buccal cusp of the upper 6 in contact with the mesial slope of the mesobuccal cusp of the lower 7 is making this relationship Andrew's first key to normal occlusion. The second key is introducing us to another terminology, that is crown angulation. In orthodontics, when we say angulation, it means the mesiodistal tip. The mesiodistal tip is the angulation. Normally, the tooth should not be upright. The tooth should have a very mild mesial tip, which means that the distal portion of the gingival part of the crown along the long axis should be positioned distal in relation to the incisal portion along the long axis. Okay, so this is the normal, this is the upper left, central, upper right, central. They both should have a little bit of mesial tip, not too much mesial tip. This is not normal, okay, and not distal tip or being upright, okay. So this is a normal crown angulation. Now, crown inclination. In orthodontics, inclination means torque, and this is the buccal lingual inclination. It's in that direction. Normally for the upper incisors and the lower incisors, the crown should have a labial torque. Normally, it should have a labial torque. So the angle between the upper incisors and the maxilla should be about around 109. The lower incisor and the mandible, it should be around 93. So it should be, it should have buccal crown torque or labial crown torque. More than this is considered proclined incisors. Less than this is considered retroclined incisors. Okay, so these terminologies are important. So the normal inclination is a little bit of buccal inclination. More than that is proclined. Less than that is retroclined. For the posterior teeth in the upper buccal segment, teeth will have lingual inclination. They will have lingual inclination. For the canines and the premolars, it will be the same lingual inclination, but as we go to the molars in the upper arch, the inclination will increase. In the lower arch, the canines and the molars, and the premolars will not have the same lingual inclination. It will progress as we move from the canine, premolars, and molars. Okay, it will increase as we go posteriorly. So the anterior segment will have labial inclination, while the buccal segment will have lingual inclination. Absence of rotations is another key to normal occlusion. Teeth should follow the line of the arch. There should be no rotations like this. For example, the lower right central incisor is mesiolabially rotated. So this is not normal. It should follow the line of the arch. The fifth key to Andrew's normal occlusion is to have no spaces. And finally, the occlusal curve should be flat or very, very mild. So this is what we call curve of Spee. This is too much curve of Spee. This is too much curve of Spee. But here in this picture, this is almost flat. So the normal curve of Spee should be minimal or flat. So these are the 6 keys to normal occlusion according to Andrews. So now we introduced you to a number of terminologies related to what is considered a class 1 or a normal molar relationship. What do we mean by angulation and what's the normal, inclination and what's the normal, and rotations, no spaces, and curve of Spee. Okay. Now, why do we need classification in any system? Well, it makes communication between clinicians easier, communication with the patient, conducting research, diagnosis, treatment planning, everything should be easier using classifications. The index is a structural scale or ranking used to allocate a feature or set of features to a particular grade or class. So indices are also used to classify, but sometimes they rank or give certain grades to the different categories. Any index or classification should have a certain requirements. It should be reproducible. It should be valid. Valid means that it should measure what it is designed to measure. So it should be accurate. Both reproducible and valid means reliable. So the index should be reliable. It should be, of course, acceptable to the professional, to the public. It should require minimal judgment. It should yield quantitative data that can be analyzed and therefore used in research, used to publish. It should be cheap. Now, the advantages of using the classification systems and the indices is to have uniformity in the assessment of treatment need. Safeguard for the patients, of course, so that we don't undertreat or overtreat. Patients counseling, if we want to communicate with the patients, it's easier to have a certain system of classification. Resource of allocation and planning, or if you have funding, for example. Monitoring and promoting treatment standards. In orthodontics, we will focus on the diagnostic classification, but in orthodontics we have indices for treatment need, treatment complexity, and treatment changes or outcome. Okay, now for the second, third, and fourth item, I just want you to know those examples. The IOTN for the treatment need, ICON for the complexity. Actually, it also looks at need and outcome. Treatment changes or outcome is the PAR index. You just need to know regarding these indices what these abbreviations stands for. If there are any different components we need to know about, what are they used for? Okay, so just what you need to focus on what we're going to talk about in this lecture. The IOTN is the index of orthodontic treatment need. It's an index that was introduced to identify patients who have a priority for treatment, and it has two components: the dental health component and the aesthetic component. The dental health component relies on certain features. It actually chooses the most severe feature and allocate the patient into 5 different grades. Grade 1, where there is no need for treatment. Grade 5, all the way to grade 5, where we have very great need of treatment. Okay. Patients who are allocated to grade 4 and 5 usually get free treatment in the UK. Patients who get grade 1 or 2 usually go to the private sectors. Patients who get grade 3, we usually use the aesthetic, the second component, which is the aesthetic component, to further assess the need of treatment. So this is one way to assess patients' need of treatment, and usually we have lots of categories and features that we need to look for in order to decide where the patient fits. For example, patients who have cleft lip and palate will have the 5P grade, which means very great need of treatment. An overjet of, for example, 3.6 to 6 millimeters with competent lips will be grade 2, which is not a great need of treatment, and so on. You don't need to know the details, but just need to know what the dental health component is. The aesthetic component, on the other hand, consists of 10 different colored photos of the frontal occlusion. Okay, photo number 1 and 2 says that there is no need for treatment. 3 and 4, slight need. 5, 6, 7, moderate borderline need. 8, 9, 10, definite need of treatment. So these are the photos, and actually you give these photos to the patient, and the patient should decide where his occlusion, where his frontal view fits. And this is one way to see how much the patient is seeking treatment, how much the patient is aware of his aesthetic. So if you choose number 9, that means he has a definite need of treatment. He thinks that his malocclusion is severe. If you choose 2 or 3, then this is a less need of treatment. So we're going to talk about another index, and that is the PAR index. PAR index stands for Peer Assessment Rating. And this index looks at the changes that results from the treatment and the success, how much the treatment was successful. Usually it relies on study models that are taken before the treatment compared to those taken at the end of the treatment. Then certain measurements are made, and then we get at the end a certain score. So the PAR index score before treatment minus PAR index score at the end of the treatment will give you a certain measure. If PAR was reduced, if the PAR score was reduced more than 70%, this is a very successful treatment. 30 to 70% reduction is considered acceptable. Less than 30% is considered of little benefit of the treatment. Okay. The other index is the ICON index, and it's the index of complexity, outcome, and need. And usually it has different features of the IOTN and the PAR index in addition to the complexity altogether. And it is used to assess need before treatment, complexity at the diagnosis, and then at the end, the outcome of the treatment. okay? So you don't need to know lots of details. For us, for this lecture, we're going to focus on the classification, and we're going to introduce you to further terminologies. For the occlusal classification, that is the intraoral, we're going to look at the anterior, posterior, vertical, and transverse, and then we'll talk about the skeletal classification also in the 3 dimensions. For the anterior posterior, we're going to talk about the molars classification according to angle. Edward Angle in the 1899 introduced this classification. He's considered the father of the modern orthodontics. The angles classification is based on the anterior-posterior position of the first permanent molar. So it is exactly what we talked about in relation to the anterior-posterior relationship between the mesobuccal cusp of the upper sixth in relation to the lower sixth, okay? This relationship is called angles classification. Now, this table shows you a bit of details. You just need to know that there is something called class 1, which is the neutral occlusion, class 2, distal occlusion, class 3, mesoocclusion of the molar relationship. Class 1 is when the mesobuccal cusp occludes at the mesobuccal groove, like we said. Very simple. This is considered class 1, and this is considered the normal, right? So again, mesobuccal cusp fits in the buccal groove. Mesobuccal cusp fits in the buccal groove. Nothing about the slopes like Andrews did. Okay, this is very simple anterior-posterior relationship between the upper and the lower first permanent molars. If the mesobuccal cusp of the upper sixth occludes anterior to the buccal groove of the lower, then this is what we call class 2 molar relationship. Okay, now here we will see that the mesobuccal cusp of the upper is actually a whole cusp, a whole unit anterior to the normal position. In orthodontics, when we say a unit, it means the mesiodistal width of a premolar, which is equal around 7 millimeters, okay? A unit is the mesiodistal width of a premolar, which is equal to 7 millimeters. So this mesobuccal cusp of this molar has jumped a whole full unit in relation to its normal position. So this is what we call full unit class 2. If the mesobuccal cusp moved forward half unit, like here, cusp to cusp, so it's not like full unit, it's half unit, we call this half unit class 2 molar relationship. If the mesobuccal cusp of the upper is positioned posterior to its normal position, posterior to the buccal groove of the lower, then we call this class 3 molar relationship. And here, the mesobuccal cusp tip has moved a whole unit posteriorly, so this is a full unit class 3. If the mesobuccal cusp has moved halfway, half unit, then we call this half unit class 3 molar relationship. So the top photo here shows class 1 molar relationship. Here the mesobuccal cusp is actually anterior to the buccal groove of the lower, so this is a full unit because it has jumped a full unit. So this is a full unit class 2. And here you can see that the mesobuccal cusp is posterior to the buccal groove, so this is a full unit class 3 molar relationship. Okay. Now, we don't use angles classification as a whole theory and a whole system like angles has used. We just simply use the classification related to the molars in the anterior posterior dimension, because angle believed that the position of the molar reflect the severity and the features of the whole malocclusion, and this is not true, because some people will have a badly distracted sixes, some people will have an extracted sixes, and the position of the anterior posterior position of the sexes actually is sometimes affected by local factors. For example, if the patient had an early loss of the second primary molar, the E, if he had an early loss of E, then what happens to the sex is that it will shift mesily, and this will affect its anterior posterior position without reflecting the severity of the malocclusion. So all these reasons actually resulted in using angles classification just to describe the molar relationship, not to reflect on any of the severity of the malocclusion. Exactly like we described the molar relationship, we can talk about the canine relationship. A class 1 canine relationship is the anterior posterior position of the cusp tip of the upper canine in relation to the lower. Class 1, it should fit between the lower 3 and 4. So it should fit in the embrasure here. So this is considered class 1 canine relationship. If the cusp tip is positioned or occludes anterior to this position, then we call this class 2. If it's posterior, then we call this class 3 canine relationship. Now, if the patient had missing 6s, what do? Well, simply we move to the 7s to describe the molar relationship, using the same principles. We can look at the premolars. For example, the 4 should fit between the 4 and 5. The 5 should fit between the 5 and the 6. So we can talk about the buccal segment relationship in general, not for necessarily a molar or a 6 relationship, okay? So basically, canine relationship, molar relationship, buccal segment relationship in general. Now we'll move to the incisors classification. This was introduced by Pollard and Wayman, but it was adopted and further widely used by the British Standard Institutes in the 1983. It is describing the anterior-posterior relationship of the upper and the lower incisors, where the lower incisal edge should occlude on the upper central incisor cingulum plateau to call this a class 1 incisors classification. So it depends on the lower incisal edge and the upper incisor cingulum plateau. So here, the lower incisal edge, if it occludes at or lies immediately below the cingulum plateau of the upper incisors, upper central incisor, we call this class 1 incisors classification. So this is a class 1 incisors classification. If the lower incisal edge occludes posterior to the cingulum plateau of the upper incisors, we call this class 2. But we should never describe the incisor classification as class 2 full stop. There should be always either division 1 or division 2. Okay, so class 2 incisor classification is not enough. You need to specify if it's division 1 or division 2. Division 1, so class 2 division 1 incisor classification is when the lower incisal edge occludes posterior to the cingulum plateau and the overjet is increased. Okay, so this is a must. But the upper incisors inclination could be normal, could be proclined. Okay, and we know now what we mean by proclined. Okay, so the inclination could be normal or proclined, but the overjet should be increased. Okay, class 2 division 2, on the other hand, is when the lower incisal edge occludes behind the cingulum plateau, but the upper incisors are upright or retroclined. This is a must. Okay, and sometimes the overjet is reduced, average, or even increased. So what's a must to call it division 2 is when the upper incisors are upright or retroclined, okay, not of normal inclination. If it's of normal inclination, we don't call it division 2. Class 3 incisor classification is when the lower incisal edge occludes anterior to the cingulum plateau, anterior to the cingulum plateau. So we can have a reduced overjet or even reversed overjet, okay, or even a reversed overjet. So this is called the class 3 incisors classification. So the top photos here shows the class 2 division 2 incisors classification, where the lower incisal edge occludes behind or posterior to the cingulum plateau and the upper incisors are retroclined. Here we'll look at this photo and we will see that the lower incisor edge occludes anterior to the cingulum plateau. So this is a class 3 incisors classification. The top photos again, class 3 incisors classification. Lower here, the lower incisal edge occludes behind the cingulum plateau and the overjet is increased. So this is class 2 division 1 incisors classification. Since we talked about the overjet, we need to define what overjet is. Overjet is the horizontal relationship between the upper and the lower incisors, and it's measured from the upper labial surface of the upper incisor to the lower labial surface of the lower incisors. And if you want to practically measure it, usually you measure it from the upper incisal edge to the lower labial surface. On average, it should be 2 to 4 millimeters, okay? And basically, could be less than that, so we call it reduced, or it could be more, so we call it increased, if it's more than 4 millimeters. It could be edge to edge where it's 0, or it could be reversed like here. Reverse, that means the upper incisors are behind the lower incisors. So this is a reversed overjet. Another name for this is anterior crossbite. So if the lower incisors are anterior to the upper, this is an anterior crossbite. Okay. So this is an example of an overjet that is increased. So this is a class 2 division 1 incisors classification with an increased overjet. Okay. This is lower incisor ahead of the upper incisor. So we call this reversed overjet. Another name is anterior crossbite. So if you measure it, for example, you report it as, for example, -2. So it has to be in the minus. Okay, so this is reversed overjet, or what we call anterior crossbite. Overbite is the vertical relationship between the upper and the lower incisors, where the upper incisors should cover around 1/3 of the lower incisors in the maximum intercuspation. If the upper incisors covers more, we call this increased overbite. If it covers less than 1/3, we call it reduced overbite. If it covers 1/3, we call it average overbite. If there is a total lack of vertical overlap, we call it anterior open bite. Open bite, okay, because there is lack of vertical overlap. If the lower incisors in the maximum intercuspation comes in touch with teeth or soft tissue, we call this overbite complete. If there is no touch, we call it incomplete. Okay, if it's complete, you need to specify if it's complete to soft tissues, like for example, it's touching the palate, the lower incisor is touching the palate, or the upper incisors are touching the lower gingival tissues, that we call this complete, or it could be touching hard tissues like teeth. For example, the lower incisor are touching the cingulum plateau of the upper, so this is complete or overbite to hard tissues to teeth. And if it's to soft tissues, it's important to check for any trauma, active ulcers, etc. So, for example, this is the amount of overbite. So the upper incisors are covering more than 1/3. It's covering about 1/2 of the lower. So basically, this is an increased overbite. Here we have a total lack of vertical overlap. So we call this open bite. Open bite. So this picture here is showing you an example of deep overbite, increased overbite, because the upper incisors are covering almost all the lower incisors. This here is average overbite, where the upper incisor covers about around 1/3. And here we have reduced overbite, where the upper incisors are covering just a little bit of the lower incisal edge. And here we have anterior open bite. This photo shows you posterior open bite. So this is how you describe the overbite. Here shows you an example of complete. So the lower incisal edge comes in touch. So this is complete overbite. And here there is no touch. So this is an incomplete overbite. If it's complete, it could be complete to hard tissues like here, or it could be complete to soft tissues like the palate. So this is actually suction. This is study models in the maximum intercuspation that has been cut in the midline, and to show you where the upper incisors and the lower incisors. So this patient actually has severe class 2 division 2 incisor classification with deep overbite, where the lower incisor actually comes in touch with the palate. So this is a bit severe, but just to show you an example of lower incisor comes in touch with the soft tissues. Transversely, we look at what we call crossbite. So we already talked about the anterior crossbite, and this is just to show you where the upper lateral incisors are in crossbite with the lower lateral incisors. So we call this anterior crossbite. Another description is reversed overjet on the lateral incisors, right? So here another example of anterior crossbite, where the upper right central incisor is in crossbite with the lower right central incisor. So this is anterior crossbite, and the overjet on this incisor is reversed. Okay. Most importantly, we want to talk about the crossbite in the posterior segment. Okay. So normally the normal transverse relationship is where the lower the lower buccal cusp of the buccal segment, the lower buccal cusp, should occlude in the central fossa of the upper buccal segment. So the lower buccal cusp occludes in the central fossa of the upper. This is the normal transverse relationship. So on the left side, on the right side, this is a normal transverse relationship. If the lower buccal cusp occludes buccally in relation to the central groove, we call this buccal crossbite. So again, the buccal cusp of the lower occludes buccally in relation to the central groove in relation to its normal position. Transversely, we call this buccal crossbite. So this case, for example, has on the left side buccal crossbite, on the right side buccal crossbite. If the lower buccal cusp occludes lingual to the central fossa of the upper, we call this lingual crossbite. So for example, this patient here on the left side, it's normal transverse relationship, but on the right side, we have lingual crossbite on the 6 and the 7 only, okay? So the 6 and the 7 are positioned outside, and the buccal cusp of the lower actually occludes lingual to the central fossa fully. So this is lingual crossbite. Another name of lingual crossbite is what we call scissor bite. If you're describing crossbite, you need to specify if it's anterior crossbite or posterior crossbite. If it's posterior crossbite, you need to specify again if it's lingual crossbite or buccal crossbite, and you need to specify if it's unilateral, only affecting one side, or bilateral, affecting both buccal segments. You need to specify teeth included. So it could be actually localized to a single tooth or few teeth, or it could be generalized affecting the whole segment. And finally, it's extremely important to specify if it's associated with or without mandibular displacement. Okay, any crossbite you identify during examination of the occlusion, you have to look for a mandibular displacement. You have to exclude mandibular displacement. So this is the occlusal classification. Now, skeletal classification, again, we're just going to talk briefly about them in the anterior, posterior, vertical, and transverse. Like the molar relationship, canine relationship, incisor classification, the skeletal classification could be divided into class 1, class 2, and class 3. And it describes the anterior-posterior relationship between the maxilla and the mandible. The maxilla should be positioned a little bit ahead of the mandible, around 2 to 3 millimeters. Okay, if so, we call this class 1 skeletal pattern. Like here, the maxilla is positioned a little bit relative to the mandible. And when we talk about the maxilla, we're talking about the deepest concavity of the anterior surface of the maxilla. This is our reference line or point. Okay, it's called A point. The deepest concavity of the anterior surface of the maxilla. In comparison to the deepest concavity of the anterior surface of the mandible, this is the B point. So A point should be ahead of B point 2 to 3 millimeters to call this class 1 skeletal pattern in the anterior posterior dimension. If the maxilla is more than that relative to the mandible, if it's anteriorly positioned more than 2 to 3 millimeters, then we call this class 2 skeletal pattern. An anteriorly positioned maxilla is called prognathic maxilla. A posteriorly positioned maxilla is called retrognathic maxilla. An anteriorly positioned mandible is called prognathic mandible. A posteriorly positioned mandible is called retrognathic mandible. Okay, so these terminologies are important. So if the maxilla is prognathic and or the mandible is retrognathic, then the result is class 2 skeletal pattern. If the maxilla is retrognathic and or the mandible is prognathic, then this is called class 3 skeletal pattern. Okay, so you just need to focus on the basic terminologies. Vertical proportions, usually the mid-face and the low face should be around 50-50 to call this a normal vertical relationship. Transverse relationship, the face should be symmetric. Let's say it should have an acceptable symmetry. There is no perfectly symmetric face. That would look weird. There's always a little bit of asymmetry that is acceptable. But for this patient, for example, there's an obvious asymmetry while the lower chin is pointing to the right. Okay, so this is facial asymmetry. Now we're going to come to only a few points left in relation to the aims of orthodontics. Why patients seek treatment? Why do we provide treatment to patients? The majority of patients comes for aesthetic reasons. Only few will have function need or dental health need. And again, also few will be referred from other disciplines to facilitate the treatment of other specialties. For example, a clinician who wants to fit an implant in a narrow area might need orthodontic help to open further space, for example, or align teeth around the implant site. So this is our job. We sometimes facilitate other forms of dentistry. Are there limitations to orthodontic treatment? Of course, we cannot treat all malocclusions by orthodontic treatment only. Sometimes we need the help of surgeons, sometimes we need the help of other disciplines. So we call this multidisciplinary cases. And it's important to understand that in orthodontics, we can only move teeth within the boundaries of bone. We cannot move teeth outside bone. We are very limited to the skeletal pattern and the skeletal discrepancies, okay? We're limited with patients' cooperation, patients' dental hygiene, patients' medical conditions, okay, financial factors, availability of materials, the clinician's knowledge and experience. We need to know that the movement of teeth has a very unclear effect on profile, on temporomandibular joint, on dental health sometimes. Okay, so this is not a clear area. Stability and relapse. Any patient who has treatment, orthodontic treatment, usually is warned about the need of retention of the results for life. So they need to wear the retainers for a long time, indefinite time. So this is why sometimes some cases need plan B, need a compromised treatment. Some cases will need multidisciplinary treatment. We cannot always provide the comprehensive, the ideal treatment for all patients. I think this is the last thing to introduce you to, and that is the different appliances that we use in orthodontics. Just simply, we categorize the appliances into three categories: removable appliances, functional appliances, and fixed appliances. Removable appliances are those appliances that can be fitted and removed by the patient himself, of course, following the instructions of the clinician, of course. They usually provide very simple type of tooth movement, mainly type of tipping movement. Simple aims are very limited and the uses should be very specific. Functional appliances, as the name indicates, the function modifies soft tissues surrounding teeth in order to produce functional forces that we talked about when we talked about definitions of orthodontics. So these are called functional appliances and they are used for growth modification. What we call orthopedic effect, okay? Orthodontic effect is to move teeth. Orthopedic effect is to modify the skeletal pattern, growth of bone. And finally, fixed appliances. Fixed appliances are used to move teeth bodily and control the position of teeth in 3 dimensions. They're usually used if you're planning for a comprehensive treatment for the patient. And this is just a very simple classification of the appliances that we use in orthodontics. So please, for this lecture of today, I want you to focus on these new terminologies. So you need to know what a molar relationship in terms of definition. What do we mean by molar relationship? What are the different classification of the molar relationship? Class 1, Class 2, Class 3. What do we mean by full unit, half unit? Incisors classification based on what? What do we mean by Class 1, Class 2 Division 1, Class 2 Division 2, Class 3? Canine relationship, overjet, overbite, crossbite, anterior open bite. What do we mean by skeletal Class 1? What do we mean by average vertical proportions, facial asymmetry, etc. So these terminologies are important. In general, what indices we use in orthodontics. Thank you for listening, and we will provide you with the online materials soon on your e-portal. Thank you.